right, everyone. Good evening. I'm Nirali Bora. I'm an associate professor here at Stanford in stroke neurology, and I'm really excited to be co-chairing this Bay Area Silicon Valley RightCare initiative with Evelyn, who's here from cardiology and UCSF. Our fearless leader, Hattie Hanley, has the flu, so she's not here. And a public health message to us all to stay home if you have the flu, right? But I'm really excited, and I think people will just filter in as they come, to welcome our guests today and to really introduce this topic that we have been alluding to in the RightCare for a while, but really getting at community-based interventions, low-cost interventions, and reaching the broader audience. We have been talking about population health level impact, but also introducing technology, and I'm really excited today to hear about kind of how we can interface on both of those things. We have many guests from the county, which is very exciting, as well as our other speaker who Evelyn will introduce shortly. But before we do that, I thought maybe we could just go around the room, as we always do, and just introduce yourself and maybe talk about a community-based intervention you've been involved in or you've heard about that you think could work in our counties. Some food for thought, a little bit different today, okay? So, Evelyn, can I start with you?
Oh, sure. All right.
And the county people have an advantage, but that's okay.
So, I am Evelyn Stock. I'm a cardiologist at UCSF, and my main area of expertise is prevention of cardiovascular disease. I'm an endocrinologist by training as well, and I work mainly in lipid research. I would say my main experience in community interventions was in Chile, where I trained in medicine and endocrine. I worked in a public hospital that served a community of about 2 million people. This was a small hospital, and we had a very high patient load, and the main people who would help us reach out to our community were the social workers. So we worked very closely with our social workers who were very well versed in law. They knew the law better than the lawyers, and they could get people services. They would put people on housing lists. They would get people their medication. They would help them get appointments with us. So basically, when somebody was discharged, you would call their social worker, like calling their mom. I'm discharging your patient, and they would go visit them in the community, and sometimes I would go with them. So I joined them I was a resident in internal medicine, so we would go into the community and visit these people in their houses and see how they lived, and we made surveys, that if they had a floor made out of dirt, or so we would tab all these things. And so those surveys, I don't know if they ever came to anything, but that was my experience.
Yeah, awesome. Thanks, Evelyn. Okay, don't give away your whole talk. But
I'll just introduce myself. Daniel Zoughbie. I'm very pleased to be here, and I look forward to the presentation.
I'm Bob Kaplan, and I come up every time, so you guys have seen me too much. But, so I'm a health services researcher. I was actually thinking a little bit about community programs. I've been involved in for a long time, including RightCare from the very beginning of it. And I was talking to Hattie the other day about some of the things that we haven't devoted enough attention to, and one of them is tobacco control. When I was at UC San Diego, we ran the state hotline on cigarette smoking control, and I also was quite involved in that when I worked in the NIH. So it is something in California that I think that we need to pay more attention to, even though we do pay attention to it. I was intrigued by the Surgeon General's report that came out the other day, and points out that about almost half of smokers are never advised by their physicians to stop. So it's an area where I think we could just do much better.
I am Hector Rodriguez. I'm a professor at UC Berkeley in the School of Public Health. It's my first time here. It's great to be here. Two programs I think I'm having a hard time choosing between. One is Health Leads, and it's been implemented across the country, but the one I'm familiar with is because lots of my students at Berkeley go and do their senior thesis, undergraduates do it with them and work. And essentially it's, so primary care practices are really busy, and if we want to address the social needs that affect diabetes, like housing insecurity, food insecurity, et cetera, we need to make it easy for patients to get the right resources, and we can't rely on physicians and necessarily even team members to do that. And so Health Leads kind of engineers the information out of the workflow into kiosks right outside the clinic that they keep up to date. And so of all the resources available, and so if a patient, the doctor writes a prescription for these needs, social needs, and that team is responsible for connecting the patients and ensuring that the loop is closed. Because I think part of the challenge in cross-sector work is that there's no loop closed. We make a lot of assumptions about who's doing what. And so I think that model appeals to me, and I think what I've heard about Santa Clara County is kind of disjointed, a little bit, with respect to medical care and social and community-based services. So I think some kind of way to standardize the connections to enable better connections for people with diabetes to community-based resources. The other one is obviously DPP, the Diabetes Prevention Program, and I think the challenge for that is scalability of that model. I mean, it has 14 sessions, and so is it through innovative technology in here in Silicon Valley? Can we figure out a way to test the effectiveness of a technology-enabled DPP that maybe doesn't rely on in-person visits so much? So anyway, those are kind of two.
Oh, I'm supposed to remind everyone that we don't have a microphone, but we are Zooming the meeting. Hattie is listening from home, and so if you could just project, everyone just project.
Eleanor Levin, cardiology, formerly at Kaiser for 29 years, now at Stanford for the last 2 years. And so many programs. I'm just going to narrow down to address the smoking cessation. That one thing that we did at Kaiser is we made smoking as a vital sign. We had exercise as a vital sign also, but the medical assistant, besides taking the blood pressure and the heart rate, would also take smoking history and exercise history. And if they were a smoker, which actually ends up being very rare as time goes on, they're less than 10% smokers, is they would then give them handouts with the smoking hotline for the state, with the smoking cessation classes, and then they'd alert the doctor that the patient was a smoker. The pharmacy then had a thing where you would just, into Epic, you would just write smoking, and it would give you what meds to give based on how many cigarettes the patient smoked per day, how much of patches, how much of Chantix or Wellbutrin were advised based on how many number of cigarettes per day, and then you could just add that prescription. It came out as a cookbook. You just clicked and then signed it, and all you had to do was counsel the patient. And then there was a mandatory click if the patient was a smoker that you gave the smoking cessation counseling in the visit. So just, if you make things easy for people to do, they do them.
Hello, I'm Poonam Gorakshakar. I'm one of the regional medical directors of Blue Shield of California. So I think I'm the only health plan representative here. So I can share a couple of different things that Blue Shield is doing in this community space. And it's actually very exciting. We've just started a pilot in the Sacramento area in doctors' offices where we have placed community health advocates. They've been trained, and they're actually embedded in their doctors, in the primary care doctors' offices, just to address the social determinants of health, the issues, what are their needs, and then connecting them to the local resources. So it's a pilot to see if that's gonna be effective, because we've learned that, the physicians just don't have enough time, but the health advocates will have access to the EMR, they can talk to the patients and understand their needs better because they're local. So that's one of the big things that we're doing. We're working with a company called My Sidewalk, I think it's called My Sidewalk, and they actually have all these different programs which tell us which areas, which zip codes have food insecurity issues, housing issues, so we can use that information to identify, what are the needs of the IPAs that we're working with and the medical groups that we're working with and the communities they're in. So it's not just the clinical needs, but the psychosocial needs. And we also work with an organization called Partners in Care Foundation. I don't know if some of you are familiar with Partners in Care. They're pretty big in Southern California, and they have community health advocates. So we've also partnered with them, and they go out and they are our eyes and ears for our health plan. Basically, our case managers, once they connect with patients, and they need to see what's going on in their homes. We send out Partners in Care, they go out, and they've shown some tremendous, results. They've worked with UCLA, and they've shown some tremendous results in terms of readmissions and things like that. You spoke about, Rodriguez, you spoke about the DPP program. So Blue Shield also has partnered with Solera. It's a pretty big company which has a lot of different resources, and it's app-based, technology-based, and we offer that directly through Blue Shield for free. So I think we used to offer Noom. Some of you may have heard of that. We just actually got a different company now. We're not working with them anymore, but that's one of the companies we've worked with in the past to do diabetes prevention, diabetes management, obesity management, all sorts of stuff. So we're working on that. And I think you also touched on smoking cessation. So just to add, I am also practicing clinician, so I still work at the hospital. And at Sequoia Hospital here nearby, we actually have smoking as literally, it's an ask, are they smokers? And if they are, we get a whole drop-down menu about the medications that we have to give them. And before, at the time of discharge, we have to also say, hey, address the smoking part of it as well. So that's being taken care of at least the Dignity Hospital that I'm at. So.
I'm Evelyn Michaud. I'm a medical liaison with Janssen Scientific Affairs, so I don't have all this community-based intervention. I've been providing education related to the therapeutic area we've been working on in the past, but never intervened myself. But looking at the clinical studies we have done in the past and the one we're doing now, we're looking more at value-based research, and we're looking more and more at intervention, and especially when it comes to trials where we know we have outcomes, we're looking at the next step. And what does that mean? How can patients get access to them? How can we help clinicians provide this access and close the loop? So this is great for me to learn about what you're doing, what you're interested in, because this is, I think, the way we're going on our side as well.
Jeannie Rizzuto with Johnson & Johnson, and I think a little bit what Poonam was talking about, we've kind of been in a trifecta or a little bit working with like Hill Physicians, with Blue Shield, with a diabetes shared decision-making tool that J&J had worked with ME Solutions on in development. There's no product push with this. This is strictly where the patient has some decision-making process in with it, where the doctor may see, or I know Hill was using their virtual pharmacist, and I know when Josie Wong was with Blue Shield, looking at patients who are still not being managed, and the doctor doesn't have the time to stay up with them all the time, so the virtual pharmacist would intervene, or even if the doctor would say, hey, I'd like you to go to this site, which usually was within their own patient portal, and they can answer the questions, and then it's EHR compatible and also with Epic, so then that information would be downloaded so the virtual pharmacist could look at it as well as the provider, and then see if the patient's like, I want to take an injectable. or I want to take a drug that's going to make me gain weight. So they already knew up front what things they might be able, so when that visit came or the virtual pharmacist could work with, hey, we're going to maybe look at these others to help where the patient might be more inclined to take the medication. So that's just one example, and then there was also helping with understanding the disease state and so forth.
Let's keep going. We're just introducing ourselves and saying a community-based intervention that we're sort of proud of or have known about to share. Let's stick to just one because we want to get through and get started with the speaker next. One per person.
Oh,
Yeah.
Hi, I'm Annie Wu from American Heart Association. For the past 4 years, we have our local chapter, I guess, or office in Santa Clara County has run a hypertension education program, mostly in North County, where we basically use very, very community and grassroots methods to recruit patients. We literally go door to door. We hire volunteers and community health mentors who literally go to parks, stores, and door to door to really reach people who otherwise would not have gone to a doctor's office or a community center. And it's just amazing the type of people we are able to impact with our program. Like people who really, like they would just say, like, I didn't think I would have access to any health services, you know, and who haven't seen a doctor in many years, and we're able to, you know, be connected to healthcare services throughout the program.
Good. So I'm David Abramson. I'm Vice President of Medical Affairs at Ameren. Ameren is a small little company that's just come to market with a very pure form of EPA. We're very excited about the possibility of this adding beneficial sort of outcomes parameter to very high-risk patients. So the project that we just started, actually, Dr. Levin's probably be interested, is with Kaiser. And this is looking at populations that we don't focus enough attention on in our clinical research. So we did an 8,000 patient study over 5 years. And as with all these large outcome studies, the number of African Americans, Hispanics, Southeast Asians really was minimal. And so what we're doing with Kaiser through up here in the Bay Area is looking at about 500,000 of such types of patients at high risk and looking to actually start some sort of implementation program to address risk. The other organization we've just partnered with, in fact, I just came from the meeting, is with the Department of Defense, looking at women in the DoD and looking at treatment disparities, where we'll add in this modality of therapy in very high-risk women. So I think that's an area we're very interested in, is exploring other populations that traditionally have not been studied in these large outcome studies, or at least the percentage enrollment in those trials has been low.
I'm Susan Hansen, Medical Science Liaison with Amgen, and we're doing something very similar to what J&J and Janssen are doing. But what I was most proud of for working in the public health sector was in college, before getting my PhD, I did a rotation through the public health department, and some of the things that are now being implemented through Blue Shield were some of the things we did then, and the outreach was tremendous. You know, what we were able to succeed in getting patients connected to resources, improve blood sugars in the diabetic patient population. It was really quite profound, and something I may go back into at a later date. So.
I'm Helen Norman. I'm with the Santa Clara County Public Health Department, and I've had lots of experience with public health. But most recently, I've been working as an independent consultant with several health organizations working on prevention strategies. We know that prevention works, and the most recent project that I worked on was with the county behavioral health department. And one of the things that we found, and I think it's true in public health as well, is that we all have a different definition of prevention and what works in prevention. One of the things that we found is that we have a workforce shortage. people who are actually trained to do prevention in clinical and community-based settings. So what we did in behavioral health, we actually created a prevention specialist training program that was approved by the State Department of Education, and now the County Learning Partnership offers that course. It's a 40-hour course to teach people the elements of doing community-based prevention. So I'm hoping we can bring that to the Public Health Department for chronic disease and diabetes prevention.
So I'm Bonnie Broderick, also with Public Health, and we're thrilled to have Helen join our team and take her learnings from the behavioral health into public health. I've been working in public health, and almost all my examples are community-based, and so we were very happy that Kaiser helped us bring in Ask, Advise, Refer to our health and hospital system 8 to 10 years ago. We had really good support. We do a lot of population health. So I'm just gonna, this is gonna be very far off from everybody else, but one that we were talking about today is just really looking at change in the environment, the social determinants of health, the environmental determinants of health, and behavioral determinants of health in South County down in Gilroy. We're doing some work through this, we're calling the Safe Routes to School program, but it's really safe routes for everyone, everywhere. So really working with the cities on policy changes, the school districts on policy changes, the neighbors in terms of advocacy and community engagement to change the way the community is designed and the way people interact and interface in their community so they can have more active, helpful lives. And so those are a lot of type of interventions that take many years and many partners that we love having medical providers on board. They bring another perspective to it in terms of our clinics. And so, again, public health, that's what we thrive in, is the community side.
And do you want to take a moment to address Hector's concern? You mentioned that about disjointed.
We even have to the social determinants of health.
This is.
Oh, it's good.
This
I feel like you should have a chance to respond.
Oh, I'm not saying, I have no reference point to other.
All counties.
Yeah, but what, I went to the social determinants of health symposium in the county, and that's what I heard in the audience. Like,
Yeah.
people were a bit lamenting that we should coordinate a bit better across community-based organizations in the healthcare sector. So I was hearing it from the audience.
Any
at that meeting.
strategies?
Oh, no, we'd echo it, and that's in part, absolutely. We've had a diabetes prevention collaborative, we're looking at pre-diabetes, and even just raising awareness of pre-diabetes, because I think it's 685,000 people in Santa Clara County, but people don't know it, and we don't have systems of care, and we're doing some work with our hospital to even screen for pre-diabetes, but that's not universal yet in ANCs. So we do have big health issues and definite needs for systems of care, and I think one of the things from that social determinants of health, and Annie was part of that planning group too, is really where do we go now? I mean, so we know we have these big issues, we have a little bit more focus on upstream prevention. Who are the key players that can work together to move it forward? And so, again, we look forward to bringing more back, and that's again part what Helen's really come on board to help us with as we really look at where do the key stakeholders in Santa Clara County want to go on the prevention side, way upstream prevention, primary prevention, I think primarily.
And then Victoria entered, you wanna introduce yourself?
Everyone, sorry I was late. My name is Victoria Dupuy. I am the founder and executive director of a small but very mighty nonprofit in Santa Clara County called No More Broken Hearts. And we do, we have a mobile clinic, and we do coronary artery calcium scans in the community. We've screened over 400 people since July. With about 35 people we are finding have some level of heart disease. We have 7 so far that I know of that have gotten stents because they've been scanned on our mobile clinic, and we're just looking forward to 2020 and ramping that up even more in Northern California.
Well, I think a lot of what everybody mentioned are really great programs that are going on, but also asking good questions about what else can we do, how do we connect more, and so Evelyn's going to introduce our speaker, who's going to talk about another tool.
So I want to thank Danny and Zoughbie for coming today to talk to us about leveraging social networks and blood sugar and blood pressure control. So Daniel Zoughbie is the founder and CEO of the Microclinic International. It is a nonprofit development organization that he started way back. I was telling him I watched his YouTube video from 2008 where he got a distinction from a organization called the Do Something. So he's a Bay Area native and has been working in these microclinic idea. He's gonna tell us about it, and he has experience since 2000 something, 2005, working on these microclinics in the Middle East and then in Appalachia County here in the US. And he also studied in Oxford, and right now he's back in Berkeley working as in the International and Area Studies at the University of California at Berkeley, and is the vice chair of the Center for Middle Eastern Studies. So we are so delighted to have you. We'd love to hear all about your work and your vision.
And again, apologies, no microphones, so
Yeah,
just
that's fine.
use
Should
your
I
outside
stand
voice.
up?
Yes,
Yeah.
that would be great, thank you. I think the sound will be best.
Okay, good. Where, just so I know, where's the Zoom camera? Is it here or?
Yeah, so it's just microphone.
Oh, I see.
Yeah, and then we're sharing our screen so they can see the screen as well.
Okay, good.
Did you act on it or you're waiting?
Okay, thank you again for the very kind introduction and the invitation to be here and share a little bit about some of the work that I've been doing for well over a decade. I think one of the interesting ways to begin would be to reference a new study that I think sadly has not received the sort of international media attention that it should have. And that's a new study coming out of the UK by Professor Roy Taylor, who believes that he's sort of discovered a cure for diabetes, type 2 diabetes. And that cure is rather simple. It's not a pill. If it were a pill, it would probably be worth several $billion. It is a dietary intervention, a rather severe dietary intervention that involves restricting calories to 800 a day for a given period of time, and then sort of gradually changing. But you know, this just sort of reinforces this concept that many of us, I think, have worked on, which is that prevention of diabetes, prevention of type 2 diabetes, is really something that is directly related to how we move and what we eat. It really doesn't have to be something that is incredibly complex. Of course, it can escalate to that level if it's not dealt with. Additional research from Harvard suggests that 90% of diabetes, despite its genetic dimension, is preventable. So my story starts with not these facts, but more of a personal observation. My grandmother passed away from diabetes complications in the Middle East. When I was an undergraduate at UC Berkeley in 2005, I was thinking about what I wanted to do for my graduate work and also for my senior thesis. And many of my colleagues had written, great pieces of research on, this thing or that thing, and they'd gone to libraries, and some had even done field work. But I wanted to do something that was a little bit more practical. So to bring together practice and theory, to bring kind of field experience with my scholarship. So I went to the Middle East, and one of the things that I observed was that, first of all, the way people were eating was clearly driving this epidemic, and many people, including my grandmother, did not have adequate information